Imagine a medical implant procedure with a 96% complication rate.
I mean, that is just a wild number to even try and process.
Right, it's staggering.
Yeah.
A procedure where the intended fix uh, literally tears through the fragile tissue it was supposed to support.
Yeah, leaving the patient in a much worse situation than before they even walked into the clinic.
Exactly. So today we are looking at why treating complex women's health issues like, a simple plumbing problem is causing these mechanical interventions to just spectacularly fail.
It really is a phenomenal case study in what happens when medicine completely ignores the underlying biological foundation.
Right.
We really like the human body to behave like a machine. We want to identify a structural failure, patch it up with something, and just move on.
A quick fix.
Exactly.
Uh-huh.
But when you step into the world of the pelvic floor, especially during menopause, that mechanistic view just completely falls apart.
Well, welcome to today's deep dive. We're exploring a fascinating and, frankly, urgent medical intersection today. We're looking at genitourinary syndrome of menopause, or GSM.
Which is a crucial topic.
It really is. And we're looking at the physical, biomechanical changes that happen in the pelvic floor when estrogen drops.
Yeah, the mechanics of it are wild.
So for you listening, our mission today is to unpack how severe estrogen deficiency and mucosal thinning absolutely dictate the mechanical stability of things like anterior wall fillers.
And urethral bulking agents, too.
Right. To get to the bottom of this, we are pulling from a stack of really specific medical sources today.
We've got some great data. We're looking at clinical trials on hyaluronic acid and urethral bulking agents, specifically a synthetic material called Tegris.
Yeah, that Tegris data is intense.
It really is. And we also have a groundbreaking study that used a scanning haptic microscope to measure live human vaginal tissue.
Which sounds like sci-fi, but it's real.
Totally. Plus, we've got a long-term transcriptomic study on ovarectomized rats that maps out all the genetic and cellular changes of estrogen loss.
So if you are, say, prepping for a medical device meeting, or you're just insanely curious about the hidden architecture of the human body, you are definitely in the right place.
Absolutely.
We want to help you understand that treating things like prolapse and incontinence, it's not a spackle over the cracks kind of situation.
No, not at all. You can't just patch it.
Right. But before we look at how these fillers actually behave once they are inside the body, we have to look at the environment they're being injected into. Like, what actually happens to this tissue when the estrogen runs out?
Well, the clinical term you will see in the literature is genitourinary syndrome of menopause,
Yeah.
GSM.
Okay.
It's the updated, I guess, more comprehensive term for vulvovaginal atrophy. And the statistics here, they are just staggering.
Yeah, let's talk about the numbers.
It affects 50 to 70% of postmenopausal women.
I really want to pause on that number for a second. 50 to 70% of roughly half the population.
It's a massive demographic.
It's huge. That is a massive group experiencing profound physical changes, yet there is so much silence around it.
Oh, completely.
People are dealing with severe dryness, burning, painful sex, and urinary incontinence. And often, they don't even tell their doctors.
Because of the stigma, right?
Yeah. There is this pervasive cultural gaslighting that tells them, well, you're getting older, things just stop working, deal with it.
And that silence prevents patients from understanding that this isn't just vague aging.
Right. It's not just getting old.
No. It is a highly specific, measurable cascade of biological events. The core driver is the loss of estrogen.
Okay, so what exactly happens when the estrogen drops?
Well, when systemic estrogen levels plummet, specific cells in the mucosal lining, which are called fibroblasts, they essentially go to sleep.
Oh, to sleep.
Yeah, the medical literature describes them as entering a state of metabolic rest.
Okay, and fibroblasts, they're basically the cellular factories of the tissue, right?
Exactly. They are the master builders. They're responsible for actively manufacturing the vital components of the extracellular matrix.
The biological scaffolding.
Right. The matrix is the biological scaffolding of the tissue. It's made primarily of hyaluronic acid, elastin, and collagen.
So when the estrogen disappears...
The factories shut their doors. The production just stops.
Which brings us to that long-term transcriptomic rat study from our sources.
Well, this study is fascinating.
Yeah, the researchers looked at rats 7 months post-ovariectomy. And just for context, in the accelerated timeline of a rat's lifespan, 7 months effectively simulates long-term established menopause.
Right. It's a great model for human menopause. And the findings there illustrate the sheer scale of the shutdown.
What did they find exactly?
The researchers documented a severe systemic drop in the body's biosynthesis of specific amino acids, namely glycine, proline, and hydroxyproline.
Okay, let's translate that chemistry for the listener, because those aren't just random ingredients floating around in the bloodstream, right?
Far from it. Those three specific amino acids, they link together to form the physical chains of collagen.
Oh, wow.
Yeah, in fact, they make up 57% of collagen's overall structure.
Over half.
Yes. So if the fibroblasts are in metabolic rest and the body stops synthesizing glycine and proline, the tissue literally loses the raw materials needed to manufacture its own scaffolding.
So the tissue is essentially starving itself of its own structural integrity?
That is exactly what's happening.
The sources mention this causes a profound thinning of the vaginal wall, all the way from the top epithelial layer down to the deeper adventitia layer.
Right. The whole cross-section is compromised.
But just to visualize that for you listening, the epithelial layer is that surface-level mucosal lining, the part you could theoretically touch.
Yes.
And the adventitia is that deep, tough, structural casing that wraps around the organs and holds everything in place. So the whole cross-section just shrinks.
The architecture completely degrades. It just falls apart.
Okay, let's try to unpack this with an analogy.
Yeah.
So is this essentially like a mattress losing its metal springs, like the collagen and its memory foam, the hyaluronic acid, at the exact same time?
That is a highly accurate way to visualize the extracellular matrix. You lose the bounce of the springs and the volume of the foam simultaneously.
That sounds like a terrible mattress.
It is, and it triggers a massive domino effect. When you lose that matrix, you also lose the microscopic blood vessels that were suspended inside it.
Oh, I see.
So the tissue suffers a severe reduction in vascularization.
So it's not just getting thinner, it is being actively starved of blood, oxygen, and hydration.
Which is the direct biological mechanism behind the symptoms that these women suffer from. The lack of blood flow and hydration causes the burning and the dyspareunia.
Dyspareunia being painful intercourse.
Correct. Furthermore, this starved environment alters the local pH. It moves it from a healthy acidic state to a more alkaline one.
And pH shifts are never good news for the microbiome.
Exactly. That pH shift wipes out the protective microbiome, which is exactly why these patients suffer from recurrent urinary tract infections.
Yeah.
The defensive barrier is just gone.
Okay, so the mattress is flat, the blood supply is gone, the tissue is paper thin, but here is where it gets really counterintuitive.
This is the crazy part.
Right. Now that we know the tissue has physically degraded, we have to look at how its mechanical behavior changes in the real world.
Because it's not what you'd expect.
Not at all. This leads us to what I think is the most surprising paradox in the entire stack of research today. The paradox of stiffness.
It completely upends how we normally think about tissue weakness.
So our sources include this fascinating study that utilized a scanning haptic microscope. And haptic technology allows researchers to physically press and measure the mechanical properties of live human vaginal tissue.
Without destroying the samples, which is key.
Exactly. They were comparing postmenopausal women who had pelvic organ prolapse against healthy premenopausal controls.
And the results were so counterintuitive.
Right. They found that the anterior and posterior vaginal walls of the women with prolapse were actually significantly stiffer.
Yes, stiffer.
And the data correlated the stiffness directly to a lower protein expression of collagen III. But wait, I have to push back on this concept a little bit.
Sure, go for it.
I'm thinking about building materials. If the foundation of my house is stiffer, that's a good thing. It's solid. How does a stiffer anterior wall lead to organs literally prolapsing or falling down?
It is a perfectly logical question. I mean, assuming we're talking about concrete or steel.
Right.
But biological materials behave completely differently. Stiffness in this specific biological context does not equal strength or support.
Okay, so what does it mean?
It indicates a critical loss of elasticity, resilience, and shock absorption.
So stiffer means something more like brittle.
Exactly. Let's compare a thick, fresh rubber band to a dried-out twig.
Okay, I'm picturing it.
The twig is technically stiffer, right? It doesn't bend easily.
Right, it resists bending.
But the moment you apply sudden pressure to it, it snaps. The rubber band yields, it stretches under the load, and then instantly recoils back to its original shape.
And that stretch and recoil, that's what the pelvic floor is doing all day long.
Every single time you take a step, or cough, laugh, or jump, a massive wave of intra-abdominal pressure pushes down on the pelvic floor.
Like a trampoline.
Right. A healthy extracellular matrix absorbs that wave. Now, to tie it back to the haptic microscope study, collagen III is what provides the baseline tensile strength. But collagen the third, working alongside elastin, is what provides the stretch and recoil.
Okay, I see where this is going.
Because the sleeping fibroblasts are no longer producing collagen the third and elastin, the tissue becomes that dry twig. It is rigid and brittle. It literally cannot absorb routine mechanical stress.
So under the constant, unrelenting pull of gravity or just the force of a random sneeze, that brittle tissue can't bounce back. It experiences a catastrophic mechanical failure.
The tissue yields permanently. That mechanical failure is what leads to the anterior wall sagging, organs prolapsing downward, or the urethra losing its structural hammock.
Which results in stress urinary incontinence.
Exactly. The physical seal just breaks.
Wow. Okay, so because the tissue has mechanically failed, modern medicine naturally steps in and attempts to offer mechanical solutions.
That's the go-to response.
Right. The goal is to physically prop the tissue back up, to artificially replace the volume that the fibroblasts stopped making.
And there is a massive market for this.
Huge. According to the surveys in our sources, roughly 35% of women completely refuse hormonal treatments like systemic or local estrogen.
Which makes sense. The hesitation is usually rooted in a fear of systemic side effects, or they have a personal medical history of estrogen-dependent conditions.
Like certain breast cancers.
Right, where introducing hormones is strictly contraindicated. So for that 35%, non-hormonal injectables and fillers have become the primary alternative.
Our sources detail several of these interventions. Let's look at the cosmetic and restorative side first. We have hyaluronic acid or HA fillers. Brands like Deserial Plus or Novia Rose.
These are very common now.
Yeah, doctors inject these directly into the tissue to restore lost volume, plump up the outer labia majora, and try to physically rehydrate the vaginal mucosa.
But here is the interesting part. It's not just acting like inert caulking.
All right, it does something else.
The research specifically points to low molecular weight hyaluronic acid, or LMWHA. The molecular weight is the crucial differentiator here.
How so?
Well, high molecular weight hyaluronic acid mostly just sits in the tissue and holds onto water. It provides temporary bulk. But low molecular weight hyaluronic acid is broken down into much smaller fragments.
So small that they can actually interact with the cells themselves.
Exactly. They penetrate the tissue and bind to specific receptors like the CD44 receptor on the surface of those sleeping fibroblasts.
Oh, wow. So they knock on the door.
They do. When combined with specific amino acid cocktails injected alongside the filler, this binding acts as a mechanical and chemical alarm clock.
It wakes them up.
Yes. It signals the fibroblast to wake up from its metabolic rest and actively resume the synthesis of new extracellular matrix. It is an attempt to trigger biological regeneration, not just mechanical failing.
Okay, but then we look at the interventions for urinary incontinence. And incontinence is an isolating, massive quality of life issue.
That's devastating for a lot of people.
To treat it, urologists frequently use urethral bulking agents. One of the primary materials highlighted in our data is a product called Tegris, also known as URYX.
Yes, the EOH copolymer.
Right. This is an ethylene vinyl alcohol copolymer. Doctors inject this synthetic polymer directly into the walls of the urethra to physically bulk it up,
The idea is to narrow the opening so it acts like a tighter valve.
which physically stops the urine from leaking out when the patient coughs or jumps.
It is a purely mechanical dam intended to hold back fluid pressure.
Now, I want to pull in a parallel from another source we looked at because it perfectly illustrates the trap we are walking into here.
I know exactly the one you mean, the facial filler one.
Yes. We have this extensive clinical paper on how doctors use high-frequency ultrasound to guide cosmetic filler injections in the lower third of the face, like along the jawline.
Right.
They use this incredible ultrasound technology to map out the exact depth of the masseter muscle to trace the exact microscopic path of the facial artery.
It's extremely precise work.
All of this effort is to ensure perfect millimeter-precise spatial placement of the filler to avoid complications.
Right. It is highly advanced image-guided precision. And the medical assumption there is that if you place the material in the exact right geographic location, the procedure will be a success.
But in the pelvic floor, even if a doctor uses the best ultrasound in the world, even if a urethral bulking agent like Tegris is placed with absolute geographic perfection, there is a hidden biological trap waiting.
And it's a huge trap.
Which brings us to the core focus of today's deep dive. How does severe estrogen deficiency and mucosal thinning actually affect the mechanical stability of an anterior wall filler or bulking agent once it is inside the body?
This is where the clinical narrative takes a very dark turn.
Yeah, it really does.
It exposes the danger of treating a biological collapse as a purely mechanical problem. Let's look at the retrospective chart review of that Tegris urethral bulking agent.
This specific data point is what really caught my attention when I was prepping for this.
It's alarming. The review showed that a significant portion of patients actually experienced a worsening of their incontinence in the first month post-injection.
Wait, a worsening?
Yes, the synthetic dam was in place, but they were leaking more. And this happened even in cases where the material hadn't physically extruded or pushed its way out of the tissue.
So the bulking agent created a rigid mass, and the brittle, dry twig tissue surrounding it just couldn't seal around the artificial lump.
Exactly. Couldn't adapt to the new shape.
But the extrusion data, that is where the real alarm bells go off. If we look at the FDA MAUD database, which is the federal system that tracks adverse events and failures for medical devices, the numbers are just shocking.
Shocking is the right word.
96% of the severe complications reported for Tigris, that's 45 out of 47 tracked patients, were directly related to the exposure or the full extrusion of the material. 96%.
The filler literally broke through the skin.
The biological why behind that extrusion rate is the crux of this entire issue, right?
It is the mucosa, that innermost epithelial lining of the urethra and the vaginal wall, was so severely thinned out, so compromised by the long-term estrogen deficiency, that the body simply failed to reepithelialize.
Reepithelialize, meaning the body couldn't knit the skin back together over the injection site.
Right. When you puncture tissue and inject a foreign substance, you create an injury tract.
A hole, basically.
Exactly. A healthy body heals that tract. It encapsulates the material, growing a fresh layer of healthy epithelial cells over the wound to seal the implant safely inside the tissue wall.
But these patients'
cells were too starved. They were too atrophic. They didn't have the collagen or the blood supply to perform even basic wound healing.
The sources even note that some doctors tried to prep the tissue first. They gave the patients a full month of topical vaginal estrogen therapy before the surgery, hoping to thicken the wall up.
A very logical approach.
But the atrophy was so severe that even a month of localized hormones couldn't trigger that healing response. The body still failed to reepithelialize.
So the synthetic polymer just sits there. It's exposed to the open environment of the urethra or the vagina, and the human body has a very aggressive response to exposed foreign material.
It goes on the attack.
It absolutely does.
Yeah.
The histology reports the microscopic analysis of the tissue that eventually had to be removed for these patients demonstrated the presence of foreign body granulomas.
What are those exactly?
This happens when the immune system realizes it cannot heal over the implant, so it sends swarms of immune cells to try and wall off this synthetic invader. It creates a chronic, localized ring of intense inflammation.
Wow. And the physical reality of resolving this complication is just brutal. The sources detail that fixing this required cystoscopic removal.
Which is an awful experience for the patient.
Yeah, for you listening, a cystoscopy involves threading a camera and tiny cutting instruments up into the urethra to physically dig and scrape the hardened polymer out of the inflamed, thinned-out tissue.
It's highly invasive.
And because the material had dispersed, it often required multiple painful surgical visits just to get it all out.
Yeah, it's a nightmare scenario.
So what does this all mean for you listening? Let's bring this back to our construction analogy from earlier.
I like this analogy.
You are essentially putting a heavy-duty industrial mechanical anchor into a wall that has been completely hollowed out by dry rot.
Exactly.
The filler itself, the anchor, isn't necessarily defective. The problem is that the wall holding it is crumbling. You can use the most advanced ultrasound imaging in the world to find the absolute perfect geometric spot for that anchor.
But it won't matter.
Right. If the drywall has turned to dust, the moment you apply tension, it is going to tear right out.
That is the fundamental clinical takeaway here. Mechanical stability in the human body is entirely dependent on biological health.
You can't separate them.
No, you can't.
Yeah.
You cannot just mechanically bulk up an anterior vaginal wall or urethra if the surrounding mucosa is too atrophic, too biologically asleep to encapsulate and integrate the foreign material.
The host tissue must possess enough baseline vitality to accept the implant, or it will just reject it violently.
It completely flips the script on how we view these quick-fix injectables.
It really does. It's a linear journey. We start with the loss of estrogen, which puts the fibroblasts into metabolic rest.
Right.
That stops the production of collagen, elastin, and hyaluronic acid. Without those materials, the tissue becomes stiff, brittle, and structurally compromised.
leading to mechanical failure like prolapse or incontinence.
But when a surgeon attempts to fix that structural weakness purely with a synthetic mechanical filler, that same thinned-out, starved tissue is simply too unhealthy to hold the implant,
Exactly. The mechanical fix fails because of the biological reality.
leading to extrusion, granulomas, and worsened symptoms.
It highlights a critical systemic flaw in modern medical approaches that try to treat symptoms without addressing the underlying tissue quality.
Right.
It raises a vital question for the future of pelvic floor therapies. Shouldn't regenerative medicine therapies focus entirely on waking up the fibroblasts and restoring the extracellular matrix be a mandatory prerequisite before any surgeon ever introduces a mechanical bulk into the tissue?
It makes total logical sense when you look at it that way. You have to fix the dry rot and reinforce the wood before you ever try to hang the anchor.
Biology must precede mechanics. Every time.
Which brings us to a final, really provocative thought to leave you with today. We were looking deeply at that transcriptomic rat study, the one simulating long-term menopause.
Oh yeah, this part was fascinating.
And tucked away in their genetic findings was a mention of something called ferroptosis.
Ferroptosis is a relatively recently discovered form of programmed cell death.
Okay, how is that different from regular cell death?
Well, unlike apoptosis, which is a natural cellular recycling process, ferroptosis is heavily linked to severe cellular stress, altered metabolism, and crucial to our topic today, mechanical disruption.
The researchers noted that disrupted cell-to-cell mechanical signaling in the thin vaginal wall might actually induce this ferroptosis.
Right. The cells in the pelvic floor literally require a baseline level of healthy mechanical tension and physical communication with their neighbors just to survive.
So think about the implications of this for a second. If these fragile atrophic cells rely on delicate mechanical signals to stay alive, could the harsh, unyielding physical presence of a failing extruded synthetic filler, that heavy anchor tearing through the tissue, causing chaotic tension and inflammation, actually accelerate the death of the surrounding cells?
It is a chilling hypothesis, honestly, but biologically sound.
Yeah.
If the physical environment becomes too chaotic, too rigid, and too damaging, the physical stress alone might trigger the remaining struggling cells to simply self-destruct.
So the mechanical cure could be actively killing the biological host. It is a stark reminder that in the human body, the mechanical and the biological are forever intertwined. You cannot just look at a diagnostic failure, identify the structural problem, and patch it with synthetic mortar.
Because in this landscape, the mortar has to be alive.
You have to restore the environment before you rebuild the structure.
That's the bottom line.
Something to mull over the next time you hear about a simple mechanical fix for a complex biological system. Thanks for joining us on this deep dive.